Hello, welcome to my channel, Nurturing the Nurturer, restoring strength to those caregivers who give it all. Okay, so we know being the caregiver for your loved one can be challenging enough, but caring for your loved one that is on hospice can be even more challenging and emotional journey. But I'm here to let you know that in general, the hospice team they are there to help you and to guide you, but it's important to communicate your needs and your concerns and your questions clearly. So if you are that caregiver that's saying, what are the changes that I should be looking for in my loved one because they're declining and I don't know what I should be looking for, or what are the roles of the people in the hospice team, or who are the people in the hospice team? They left what's called a comfort pack. I'm looking at the label. I don't like the medications that I'm seeing. Should I keep it? Should I send it back? Because they really did not explain it. Well, if that's you, you're at the right place. And the topic for today is caring for your loved one in hospice with assurance. And I want you to have assurance and not be scared when you're seeing the physical changes in your loved one, and know it's all a part of the process that they're going through. And if you believe that this content will be beneficial to you, like, comment, subscribe, and stick around to the end so I can give you that tip for success. Hello, I'm Yolanda, former hospice nurse and caregiver to the elderly. So who are the hospice team? Who are they? What does that involve or entails? Well, of course, there's the physician, and he or she is the one who manages the patient's terminal illness, your loved one's terminal illness. So he can prescribe medications. He can, of course, write orders. He can, of course, if you feel your loved one no longer needs to be on a certain medication, he can also discontinue a medication. So, and he works very closely with the registered nurse who will be assigned to your case, which that leads me. You'll be assigned a registered nurse, also known as a case manager, will be assigned to you. Let's see, they will visit your loved ones. Sometimes they start off with once a week, maybe they do it twice a week. What usually happens is when they come out and they see the needs of your loved one, and they will make the visits according to the needs. So if they're looking at your loved one and saying, okay, I think this person can be seen once a week, or I think they need to be seen twice a week, or I think they need to be 3 times a week, and then they can do that. But just say, if they say, well, I think she or he should be seen once a week, it's okay. Nothing's never set in stone. They can always move the visits up as the time or as your loved one decline. They can start off with once a week and with 3, 4 times a week if they want to. They are the ones that manages the medication, speak directly to the doctor. They order the medications from the pharmacy, and they can also order supplies. So, and what I mean by supplies is like if your loved one needs briefs, pull-ups, hospital bed, lotions, or anything of that nature, your registered nurse, or also known as the case manager, can order them. Some facilities also have LPNs, licensed practical nurses too, that work in the facilities. And sometimes that licensed practical nurse help that registered nurse. So the licensed practical nurse can see your loved one for what we call our routine visits. Just say if your case manager, your registered nurse, is off on vacation or just off that day, or your case manager is off having to pronounce someone else. And what I mean by pronounce is if someone has passed on, that RN may have to go and pronounce them. Then they may send the licensed practical nurse, the LPN, out to see your loved one. The LPN cannot be a case manager, but like I said, usually a lot of LPNs are good, and they can work, and they work closely with the hospice team as well as your case manager. You can also be assigned a home health aide who can come out and do bathing or personal hygiene, and some can even do some light housekeeping. Now, I want you to really speak to your case manager or that home health aide that comes out to see your loved one to do that care regarding the slight housekeeping part, because your slight housekeeping may be, I need them to wash dishes and clean up the entire kitchen and vacuum my floor. But their slight housekeeping can be, okay, all I do is after I get my patient up, I make the bed and make sure that I put the clothes near the washer and dryer so the loved one can wash the clothes. So I really want you to be clear on that, because I would hate for you to expect something that they don't offer. So I'm pretty sure each individual, and if they even do that, you may have some home health aides or some agencies say, we no longer do the slight housekeeping part. I don't know, but just make sure that that part is clear. Also, with the home health aide, it's not anything, you do not have to have a home health aide. So just say if your loved one is still able to bathe him or herself, or you're able to bathe him or her, you may not want a home health aide right then because everything is good, but nothing is set in stone. So just say as they decline, then you decide later, hey, I think we should have a home health aide. The home health aide can be assigned to you. You also can be assigned a spiritual counselor or chaplain. This person can help with processing the changes that are happening during this challenging time. They can also assist with funerals and memorial service. This is also an option because some people you may have already have a priest or a pastor or someone you speak with, and so you may not want their help. And if so, that's okay. But again, nothing is set in stone. If you decide that you want to change that and you do want to see the chaplain, then that can happen. Also, I believe from what I can recall, they a chaplain do have to make that initial visit, meaning when your loved one first get admitted into hospice, they have to make that initial visit. But after that, if you decline and no longer want them anymore, I believe that can just stop again. Because like I said, you may have your own pastor that you or priest or whomever that you deal with and don't want to deal with them. So you're also assigned a social worker, which I believe a social worker is good to have. And that social worker can be there to provide that emotional support. They can also assist with financial concerns. Now, when I say assist with financial concerns, I'm not saying they give you money. But I'm just saying if you're going through something financially or need help with something, they might can find assistance for you. Nothing set in stone, it's not guaranteed, but like I said, talk to your social worker because that's what they're there for. They also can assist in advanced directives and other resources as needed. So just say, I'll give you an example. Just say if you're taking care of your loved one and now it is become really hard and your loved one, you feel like, you know what, I can't do this anymore. It's too much. And I don't want to see them go through this decline with me. I would like them put into a nursing home to do the rest of this process. You talk to your social worker and they can see if there's any way that they can assist you with that and helping them get into a nursing home facility. You have what's called a bereavement coordinator. They provide grief support. So don't be surprised after your loved one passes away if you receive call from the bereavement. Believe from what I can remember, they can call you and check on you up to months after your loved one has passed away. There are also volunteers. Some hospices have volunteers. So just say, for example, you can never get out, you take care of your loved one, but it's even hard for you to get that time to yourself, and all you're asking for, listen, I need just a few hours. If I can get a few hours to myself, what can happen is they can send out a volunteer, and the volunteer can sit with your loved one while you go out and grocery shop or just have that little bit of time to yourself. Now, a volunteer cannot give medications. So if you go out, you can't say, hey, mom, dad, cousin, or whomever is due for their insulin shot at 2 and I won't be back till 4. No, that can't happen. They cannot give medications. Some hospices also offer music therapy and massage therapy. I'm not going to say all, but I used to work for a couple of hospice agencies that offered music and massage therapy. So that's really good because sometimes if your loved one is in pain, the pain sometimes, believe it or not, it sounds weird, but massaging or a massage can help with that pain. So, like I said, just ask the hospice agency, the company, ask the nurse, hey, do you offer massage therapy? Do you offer music therapy? My loved one is in need of, I really think that they're in need of that and it will really help them. So that'll be great. Also, I just want to say that I believe I mentioned it earlier, something about an admit nurse. So your loved one have to be admitted into hospice, usually their primary care doctor, or maybe if your loved one was in the hospital and the hospital doctor decided, okay, we would like to discharge your loved one home on hospice. And if you agree with that, then they will come home and be on hospice. Their primary care physician or main doctor has to write that order for them to be on hospice. But to fast forward, when they get on hospice, they have to be at what we call admitted to hospice. So a RN, a registered nurse, will have to physically come out and admit them to hospice. Keep in mind that the admit nurse may not be your loved one's main nurse. A lot of people get upset because they may meet that admit nurse and the admit nurse is like, they meet the admit nurse and they really like the admit nurse. And then when it's time for the regular visits, they're like, okay, I thought Susie was coming here. Susie is the one that got, and they're like, no, Susie is not that was the admit nurse. So I just want you to know that. And then let me back up. And then they're upset because a different nurse is now coming to see their loved one. So I just want to let you know that sometimes the admit nurse can be different than the actual case manager nurse that's going to be seeing your loved one. And sometimes it can be the same person. I just want you to know so you will not be in shock. Okay. So, what things have I found when I would go into people's homes? So, when I would go into people's homes to discuss about hospice, a lot of times they were scared because they saw physical changes in their loved one body and they don't know what's going on. No one explained it to them. So sometimes in the body, especially if you pale or Caucasian person, you can really see it in their body more during that last phase of the dying process, which we call the active phase. Sometimes you can see what's called mottling, and it's little purple like patches on the skin. Like I said, on us, darker skin, it's kind of hard to see. You may see on the palms, but on more pale skin, you can see it a lot clearer a lot of times. Now, keep in mind, because I don't want you guys to be like, oh my God, my cousin, I'm seeing it now, because sometimes with modeling, you can see it on a person just in general. If they have, for example, heart problems or something like that, you may see it. And it's normal on that person. But a lot of times, too, like I said, if you see that person and you've never seen the modeling, they're in what's called the active phase. And what we call the active phase is when it's close. It could be a matter of hours or a day before they leave us and pass on. You can see that modeling. Sometimes also during the end, you will see a short air exchange where they're breathing. It's hard for us to see, it's hard for us to hear, but that's also part of the process of what they're going through. Let's see, let me think. I'm trying to think of other things because sometimes, like I said, what I find is I get people who say none of this was explained and they're calling hospice every second, which I'm not saying it's wrong to call hospice every second, but I'm that person that I'm proactive and and I'm that person. If you knew this from the beginning, then it won't kind of freak you out when it starts happening. Yeah, it may be a little scary, but your mind can say, wait a minute, she or he told me about this. So I'm to expect this. So you're not as scared. Now, with that being said, they do usually give you like this little pamphlet that you can read all about the dying process and what you go through during the phases of the process of what you're going through. But I still like to tell people, because I'm not going to lie, if my loved one is going through this and they're passing along, some people are good. They read. I'm not reading. Reading is the last thing on my mind because I'm just constantly, here with my loved one and wanting to see my loved one. And maybe that's why, too, a lot of nurses do not explain a lot of things in detail because they're like, okay, we gave them the pamphlet. They can read that. But like I said, I like to explain because in my mind, if my loved one is going through this, I'm not reading nothing. So anyway, you have what's called that transitional phase. So what's the transitional phase? So that's the phase when, let's say I have had hospice patients that's up, like I'm doing, where you would look at them and you would literally not think that anything is wrong with them, right? They can go to the bathroom, they can cook, they can do just about anything. But then they start transitioning, and that's what we call that transitional phase. And when they start transitioning, so first where they was eating 100% of their meal, they may now be only eating 50% of their meal. Where they was able to walk, now they're stumbling when they're walking, or they really can't walk at all. When they were able to urinate on their own, now they're all of a sudden incontinent and they may have to wear a pull-up or a brief. So those are things of when they're kind of transitioning, their bodies are kind of changing. Maybe they could be awake, I don't know, a lot of hours of a day, but now you find that they're sleeping more. All of that is a part of it. And then you have what we call that pre-active to active phase. And when you get to that phase, that's basically where, like I said, when they were in the transitional phase, okay, they can eat 50% now, but now maybe they're eating only bites now. They hardly can eat, where until they're not eating at all. Again, like I said, you can hear sometimes when they get in that active phase, you can hear that short air exchange. Some people get what we call terminal restlessness. Terminal restlessness is when they're moving around. Just say if you have someone in the pre-active phase, I mean, they're moving so much, and we have to usually get them on medication to help relax them. Now, this may be scary, but I do want to explain this to you so you won't be shocked. So sometimes when you get a person that's in that what we call pre-active phase or active phase, and they're restless and they're experiencing like just this really bad restlessness, and it could be something underlying what's going on. When a lot of times when you finally get them to a relaxed stage, and their body is finally relaxed, they may pass on. So I said that to say, don't be surprised if you have your loved one that is actively passing away and all of a sudden you get them relaxed and they go. So that's all part of it. Also, you can get, oh my God, it was on my mind. What we call terminal congestion. So you hear this gurgling, this loud rattle, and usually it could be because secretions is here in the neck, and how we can swallow, they're unable to. And so a lot of times it's more uncomfortable for us to hear than it is what they're going through. Sometimes the doctor will prescribe like what's called atropine drops to help kind of calm that rattling down, or the scopamine patch to put behind the ear, which can kind of calm that rattling down. So again, those are things that you can see that, well, I'm saying that you may see that I do not want you to be surprised about. Again, eating less to not eating, and our minds, it's like, no, they gotta eat. We have to feed them and they have to eat. Their body know it, they know what they're doing. You can't force them to eat, because what's going to happen if you're forcing it and their body is not ready, all what's going to happen is it's going to come out. It's going to come up and out of them, because they can no longer eat. Their body know the process that it's trying to do, what it's trying to do. Something else that can be scary too for people is their loved one. They may hear them say something like, I'm ready to go home, but they're not talking about this home. They may say that they see someone. Also, they may have what we call the stare, where they're staring out in one direction and they're just staring. Let's see, what else besides the staring out? That's all I can really think of at this time. But yes, they're staring out like they can, like they're just staring at something. Also, you can see glassy eyes, where their eyes look really glassy. So again, those things that you're seeing, it's hard for us to see, but it's the process of what their body goes through. It's normal. Well, put it this way, it's not normal for you or to probably see, or for the normal eye, but me, as used to being a hospice nurse, I can tell you it's normal for what their body is going through. It knows exactly what it's going through. If you notice that your loved one is, you're giving them water and they no longer can drink and they're coughing, I just ask you to speak to the nurse about that, because now is probably time, and you could usually see that in those last phases, like I said, the active phase, pre-active phase, where they're no longer able to swallow. So you may have to get one of those little sponges, dip it in the water, kind of smash it next to the cup so you can kind of get some of the water out and wipe around their mouth. Because if you're forcing water down them, the water can get in their lungs and they can aspirate, and that's worse. So again, those are things you can look for. I thank you again for joining me. Again, if this is beneficial to you, you like it, please like, comment, subscribe, and just let me know your hospice experience, whether it was good or whether it was bad. If you have questions about it, I would try my best to answer your questions. Your tip for today is, okay, so if you're administering a pain medication, because what happens is the nurse is there unless something has changed. Hospice is there for you 24 hours around the clock, but no one stays in your house 24 hours around the clock. So a lot of times what the hospice nurse is supposed to do is educate you on what to do, educate you. And like when the home health aide come, they can show you how to change mom, dad, or my loved one's brief. They can educate you, the nurse educate you on the medications, how to give, when to give. It's really, we're there for that extra backup to help you. But what I mean by 24 hours. So for example, just say if your loved one had all of a sudden some severe pain or severe restlessness, and it's like 3 a.m, you call that hospice nurse, that agency, like, listen, this or that is happening. My mom is in some severe pain. My dad, my loved one is in some severe pain, and I need you to come out. Now, I'm not going to lie to you. A lot of times they will coach you on what to do over the phone, especially if you have your medicines there. And you have the right to, of course, do what they say, but just say if you're like adamant, like, okay, I gave this, it's not working, or okay, I'll try this, then that's fine. But if you're saying, you know what, I still want someone to come out and see my loved one, I'm scared, someone needs to come, they have to send someone, okay? Do not let anybody deny you of that. I don't care if it's 3, 4 in the morning, they must send someone out to help you. Let's see. Also, your tip for today, I'm sorry, I have to think. Your tip for today. So just say if your loved one is on pain medication. What I want you to do, and I'm pretty sure your nurse, your case manager, which is your RN, what I told you earlier, will instruct you on what to do and how to do and everything. But just say that your loved one is on medication. They're on a scheduled dose of medication and they're on an as needed dose of medication. So that as needed dose of pain medication is for what we call the breakthrough pain. So I'll give you an example. Just say you take your pain medication scheduled around the clock. You take it every 4 hours, right? So in between the 4 hours, you may have a little pain. So that's when that as needed portion can come in and you can take that, and that should hold you over until your next dose is due. I hope I'm making sense. But anyway, what I wanted to tell you, the tip for today is every time you take the as needed dose, and even the scheduled dose, I don't care, all dose, but especially that as needed dose, make sure you write it down. Write the name of the medication down, the time that you took the medication, and each time. And the reason I say that is because, just say, for example, it's no longer helping you, it's no longer working, right? And you talk to the nurse and you're like, listen, I'm taking the medication, it doesn't help me. What's going to happen is she's going to call the doctor, and then the doctor is going to say, well, how often is she taking it? And then the nurse will say, well, she or he is taking it every 4 hours, but they're also allowed to have it every 2 hours as needed for breakthrough. And the doctor's going to say, okay, well, how often are they taking the as needed? And they'll look at you and say, well, how often are you taking the as needed dose? And you'll say, well, so I take it. Sometimes I take it and then sometimes I don't. And what's going to end up happening is, more than likely, the doctor is going to say, well, tell her she needs to start taking the as needed dose. Now, if you have it all written down, that your schedule and your as needed dose all written down, clear the time and everything, dosage time and everything, then you have something to go on, because now that nurse can say, hey, doc, she's taking this medication or he's taking this medication every 4 hours around the clock, plus every 2 hours for breakthrough pain, and she's taking this amount, and this is just totally not helping. Then the doctor has something to work on. Okay, well, then let's increase this dose, or let's switch it to this medication because this medication is better. But if you don't have nothing in writing to show them, I can almost guarantee you that they're like, well, I'm not touching it. I'm not going to do anything, because she probably, or he probably, is not even taking it accurately how it should be supposed to be taken. And that's why they're not getting any relief. So I hope that helped you. And again, thank you for joining me. Tune in for my next video, and like, comment, and subscribe. Thank you.